Now I call upon Dr. Madharia for his presentation on diabetic retinopathy.
Yeah, thank you, sir. As Professor Nepalia sir has told, during the last 1 year, Dada and our team of AIOC, we are doing the Drishti program of every district. And during that, as I am talking, I belongs to Chhattisgarh and Bilaspur district. In our Bilaspur, at least 15 districts we have covered. We are going to the village site. We are doing the screening of cataract, glaucoma. We have already started, and we are going to the school also. So this program, AIOC has already started, and really, Dr. Agrawal has given a very nice presentation. Thank you for that. Now, I will start my presentation.
I would request Dada
Yes,
to take an account of a note made by him that all these activities of AIOC should be highlighted on the platform of AIOS in any form, whether it's a soft copy or a hard copy or whatever it is, because as I have already mentioned, awareness amongst ourselves is of paramount importance.
Respected Professor Nepalia sir, Dr. Mahadevan sir, Dr. Das, and our secretary, Professor Samanta sir, and off the dais, all the AIOCian. As we all know, one of the important, as Dr. Agrawal has recently very nicely pointed out and has discussed, the silent killer of our sight, the thief of our sight is glaucoma. And the next important cause of blindness is the diabetes. As we all know, India has become the diabetic capital, and presently about 8 million 7 to 8 crores people, they are suffering from the diabetes. And because of the lack of the awareness, many people, they become the blind. As glaucoma is a preventable disease, up to some extent, as we all know, this diabetes blindness can also be prevented. So I am going through a short, this is a very long topic, so we can understand the diabetes. What is the diabetes? As we all know, diabetes is a chronic disorder characterized by persistent hyperglycemia, presenting with varied manifestations and consequently resulting into micro and macrovascular complications. Epidemiology of the diabetic mellitus. This is a presentation, as we are seeing, in the world in 2000, the total number of diabetic patients was 171 million. And it is projected in 2030 that it will be reaching to the 366 million. In India, in the 2000, it was 31 million. And in 2030, it is projected to be the 79 million. So India has become the diabetic capital of the world, and it will remain for 30 years. Now, as we all know, India has become the maximum population of the world. We have crossed the China. This is not a good thing, but we have to face all the problems. This is a different configuration shows in the world map. According to the International Diabetic Federation in Europe, in 2015 it was 59.8 million, and by 2040 it was projected to be 71 million. In the Middle East and North Africa, in 2015 it was 78.3 million, and by 2040 it is projected to be 140 million. In Africa, Again, the same thing, it is increasing. According to the International Federation, 415 adults are having by 2040, more than 640 million of us will be living with the diabetes. 50% of all diabetic patients live in maximum in the China, 98.4 million, then comes the India, then comes the USA. These are the different configurations showing that 12% of the global health expenditure is spent on diabetes, and by 2040, one adult will be suffering from the out of 10, one will be suffering from the diabetes. So this epidemic, it has become almost taken a shape of epidemic, we can say roughly. So incidence of diabetes in India, it is due to lack of exercise, genetic determination, and morbidity increases due to low level of education and poor awareness, as we see in the rural area. So this is another very important thing, is dangerous pre-diabetic zone. Diabetes patients having fasting blood sugar more than 126, and this is, so the normally we consider the fasting blood sugar 100 to 110 milligram. But if it is more than 126, then he should be considered as a pre-diabetic. The diabetic patients presently is 62.4 million, and pre-diabetic is almost more than that, 77.2 million. So if awareness will not be created, then these pre-diabetic borderline patients of 77.2 million will jump into the diabetic patients. So this will be a very dangerous position. As we all know, very poor awareness of the diabetes. 25% of the urban population, to whom we say they are the intelligent people living in the city, 25% of them, they are not aware of the problems of the diabetic mellitus, the complications of diabetic mellitus. 12% of diabetic patients are aware about it, only the 12% is aware of its complication. And 40% of diabetic patients were aware of its causes, the organ damage. WHO divides this diabetic into two types. We are not going to detail of it, as we all know it. Then the prevalence of diabetes in the different states of India, it varies from 0.5 to 28%. So it is very much high, much in some of the state it is in 28%. Can diabetes affect our eyes? Blurring of that we all know, the cataract, and then the glaucoma, the incidence of glaucoma increases in the diabetes. The neovascular glaucoma, this is a very dangerous glaucoma due to complication of neovascularization of the iris. So the early diagnosis is a must, and patient may lose vision in a week or sometime less than a week when he developed the neovascular glaucoma. Then this is the most important thing we know, the cause of blindness is the diabetic retinopathy. The longer the duration, more the diabetic retinopathy. So this is the duration. If it is a duration of the 5 years in type 1 diabetes, 23% develop diabetic retinopathy. If it is the duration of 10 years, then the chances increases to almost 80%. And after the 20 years of the diabetes, almost the 50% they have lost their vision due to the diabetic retinopathy. And type 2 diabetes, lower rate of complication because they develop diabetes in late phase. Diabetic retinopathy in late phase. Investigation by direct fundoscopy, indirect ophthalmoscopy, and examination by 90D. During our district program of Dada, we visited 2 villages, so many villages in every district. There we did the blood sugar testing also, along with the ocular examination of these diabetic patients. So we find the villagers, they don't bother for the control of diabetes. What they say, I am taking tablet. बोले हम तो साहब वो दवाई जो डॉक्टर साहब लिख दिए हैं PSC वाले उसको खाते हैं बस. This is the, they think whatever tablet they are taking, it is controlling the diabetes. but we know it is not truth. These are the by OCT examination of the diabetic patient. This factor for diabetic retinopathy. Diabetic is a leading cause of blindness in Western country. Relationship of diabetic retinopathy and HB1C. This is a very important parameter for developing the diabetic retinopathy. According to the DCCT, Diabetic Control and Complication Trial in Type 1 diabetes, the tight control, very strict control of HB1C, 7.2 versus 9%. The comparison was done. 76% reduction in retinopathy. If the HB1C is well controlled, so definitely the diabetic retinopathy incidences reduces. 60% reduction in neuropathy. 54% reduction in nephropathy. According to the UK prospective diabetic study, type 2 diabetes demonstrated that the tight control of HB1C, 7% versus 7.9%, was associated with 25% reduction in microvascular diseases and strict control of blood pressure, 144/82 versus 155 by 90, result in 32% reduction in diabetic related death. So strict control of diabetes has got a very important role. Other factors modify the risk of diabetic retinopathy. As we have already discussed this duration of diabetes, it is then the control of blood sugar by diabetic control and complication trial of UK prospective diabetic study, intensive treatment of diabetic retinopathy, delay onset of the diabetic retinopathy. If it is well controlled, delays the progression of diabetic retinopathy. The different types of the diabetes retinopathy. The proliferative diabetic retinopathy is more prevalent in type 1 than the type 2. Macular edema develops in 20.1% in younger onset group, 25.4% in older onset group, and 13.9% older onset in non-insulin dependent group. Then other factors which modifies the risk of diabetic retinopathy, nephropathy, it increases the risk. Then hypertension, as we have just discussed, better the control, the progression of retinopathy is very slow. Pregnancy, it is significantly associated with progression. Then the genetic factor, this is very, very important. So persons, those who are suffering from, their parents are suffering from diabetes, there should be more awareness regarding detection of the diabetes, and if it is detected, then the every 6 months checkup he should be done. The factors reducing the prevalence and severity of diabetic retinopathy causes asymmetrical diabetic retinopathy. One eye and the other eye, both eye, there will be different. This in case of glaucoma, we get it. In case of myopia, in case of carotid artery stenosis, in case of retinochoroidal scarring, due to these are the reasons when there will be asymmetry in the diabetic retinopathy of both the eyes. The clinical feature, non-proliferative diabetic retinopathy, we are not going into detail of it. As we all know, it could be mild, moderate, severe, and very severe. Then the classification of diabetic retinopathy, mild NPDR, moderate NPDR, we all know this is the color and the angiography. Then the complication of next is the severe NPDR and very severe NPDR. This is a photograph of severe non-proliferative diabetic retinopathy. Classification of the proliferative retinopathy, these are the different features we see. So these are the different photographs of. So in this is the NPDR with succinate retinopathy. This is the proliferative with the CSAME. This is the mild case. This is the diabetic maculopathy. Diabetic maculopathy is a very, very severe case. These are the different diabetic maculopathy. The ETDRS classification, may not be easy to follow the routine. We have taken the International Clinical Diabetic Macular Edema. The diabetic macular edema may be either absent or present. Then the diabetic maculopathy, it could be mild, moderate, severe, and ischemic maculopathy. This is very important because if we are able to diagnose the ischemic maculopathy, the prognosis we can explain to the patients. For prognostic point of view, this is very important. These are the different photographs of OCT. So, these are the different OCT pictures of different type of diabetes. Now, this is the OCT classification of the macular edema, because OCT is always present in every general ophthalmologist also. So, sponge-like retina looks like, then the cystoid macular edema, then the serous retinal detachment we can see in many patients, then the traction macular edema. This is OCT examination is very important, because if the traction in the macula has developed, then all the treatment, even after giving the anti-VEGF, patient is not going to improve. And so patient should be explained, medical therapy will not help you. You should go for the surgical therapy. So then last is the taut posterior hyaloid membrane. This is another indication for the early vitrectomy. So, what is the guideline for general practitioner? Always stress on the duration of diabetes. If the diabetic duration is increasing, then the likelihood of increasing the diabetic retinopathy is more. Second, control of HbA1c and hypertension. It is very, very important. We see many patients. As one of my patients, he is having diabetic since last 20 years. But up till now, he has not developed the diabetic retinopathy. It is strictly controlled and regular eye checkup. Regular eye checkup every 6 months. Then the renal compromised patients, so those who are suffering from the renal problem, the severity increases very fast. So the strict control of diabetics is very important, and every 6 month checkup is very important. So this is the take-home message for all the general ophthalmologists. So all the diabetic patients should be seriously warned about its complication and the regular eye checkup and strict control of the diabetes, along with the other parameters should be normal. So with that, a good diabetic control, we can enjoy the excellent vision. Thank you very much for patient hearing.
Thank you, Doctor. Thank you very much.
Sir. Sir.
With the smartphone technique,
Sir.
So all diabetic patients in the diabetic clinics,
Right.
the main problem in the diabetic patient don't refer diabetic patient.
Right.
That's the problem.
Yeah. We
Such a situation,
Sir.
in a diabetic clinic,
Right.
if they are dilated and do a smartphone technique,
Sir.
Can you go to the mic?
Please, sir, mic is there.
There's a mic there.
Please introduce yourself first of all.
the
Yeah.
main problem in diabetic retinopathy is not getting patients to eye specialist. Diabetic specialists don't refer diabetic patient for eye checkup.
Right.
That's the problem.
Right.
So what I suggest is, in a diabetic clinic only, if the smartphone technique is used, then you can know the condition of retina of diabetic patients
Right.
and advise them properly.
Right. In
The telemedicine coming over.
in one of the program of our AIOC, sir, we are having a CME program for prevention of diabetic blindness, meeting along with the physicians, ophthalmologist physician. So in every district we have organized a meeting in the IMA, under the banner of IMA and AIOC, the meeting of ophthalmologists and the physicians, because the diabetic patient, they first come to the physicians. So physician has to be more aware, because as I have told, 40% people, they are not aware the complication of diabetes. They think जैसे मलेरिया हो गया, 2 गोली खाएंगे ठीक हो जाएगा, वैसे वो सोचते हैं कि हम डायोनिल लेते रहेंगे हमारा बढ़िया चलेगा. They are not aware of it. Many young patients, they came. So we are having a meeting of AIOC regarding the awareness along with the physicians. So physicians is the first person to see the diabetic patients.
In Mysore, what happened in Mysore medical college? 1 minute. about
It's not the
45
question-
years back,
It's not the question of renal vision.
10 medicine units are there.
It's very
10
strange.
ophthalmoscope was supplied. It was not used for a period of 40 years. Then it was shifted to eye department. And in government primary health centers throughout India, more than 10,000 ophthalmoscopes are lying waste.
I think your points are well taken up.
Ophthalmic assistants, whereas physicians are there in taluka hospitals.
Quite.
They don't have ophthalmoscope.
Thank you.
Actually, sir, the
Vision is not trained basically at present. Vision is not
Thank you.
trained at present that you do ophthalmoscopy. The question is, it's not a question of vision. I have seen that the dermatology, it's an era of subspecialty in the vision. The diabetic patient will go to a dermatologist. He will not go to general vision at present. You have a nephrologist, you have a cardiologist, you have a gastroenterologist. The problem is that what I have seen, that the diabetologist, the number of the diabetes is so much that he sees a patient in 5 minutes, he doesn't refer to the patient, diabetologist, not the patient. An expert on diabetes does not refer the patient in time to an ophthalmologist.
yeah.
And when I see, I tell him, have you done a HbA1c? Didn't your dermatologist told you? He says, no. One patient I noticed, HbA1c was 17.
I have made a routine,
Thank you, sir.
I have made a routine, yeah. Any diabetic patient coming to my clinic, I get it checked his blood sugar, fasting, PP and HbA1c and lipid profile. That everything I see. Thank you very much.
Thank you, Dr. Madharia, for your wonderful, meticulous presentation on a disease like diabetes, which you have rightly mentioned. There's a tremendous rise in diabetic population world over, and we in India are perhaps more at risk compared to our neighbor countries or other countries in the world. So we have to be very careful about this upcoming problem of diabetes in Indian population. You have very rightly highlighted the epidemiology of diabetes in India and abroad. You have very rightly mentioned the complications of, various clinical presentations of diabetic retinopathy, the complications, how to overcome, and your take-home message was very meticulous. I agree with all the points you have highlighted, and I again congratulate you for your wonderful presentation. Thank you, Dr. Madharia.
Thank you, sir. Thank you
Over
very
to
much.
Dada.